Welcome to the Heart of Health Equity. My name is Ashlei Rodgers. I have an amazing guest today who is also not only a friend of Health Leads, he's also a board member of Health Leads, and his name is Asaf Bitton. He is the executive director of Ariadne Labs, and he's also a primary care physician and an associate professor of medicine of healthcare policy at Harvard Medical School. Welcome, Asaf. We're happy to have you here.
So nice to be here. So Asaf Bitton, I wear a number of different hats in my life. I'm the executive director of Ariadne Labs, which is a health systems implementation and improvement center that's located both at Harvard School of Public Health and Brigham and Women's Hospital. The other piece of my job is I get to be a primary care doctor. I'm a primary care doctor in a clinic in Jamaica Plain in Boston, a clinic that I helped to build in partnership with an amazing group of people, an amazing community over a decade ago, and one that it's a true privilege to serve my patients. And I'm also a dad and I'm a husband, and it's really nice to be here with you.
Well, I'm so happy for you to be here, and you do wear a lot of hats. I don't know how you find time to do all the things, but mad props to that. You're talking about Ariande Labs and what you guys do. Can you talk about how you guys are addressing health equity on a global scale?
Absolutely. Health equity is such an important, broad, massive, multidisciplinary, intersectional topic. And healthcare equity is a subset of that, which is about the idea that the ability to access care when you need it, how you need it, in a way that makes sense and is valuable to promoting your health should be equal no matter where you are in the world. Our ability to deliver that is the fundamental measure of the excellence and aptitude of our healthcare system. You know, the final part is how we make healthcare a safer, more responsive system. So when you encounter a system, is it not only going to help, ideally, serve you, but also not harm you and actually promote dignity as you try to access and see you for who you are as a person. Certainly as a bar, not discriminate, but let's get beyond not discriminate. Let's provide dignity, flourishing, vitality, and excellence in every interaction. So we do a lot of our work really focused on communication around childbirth processes, both in the hospital, upstream of the hospital, and after birth, so that people can really have a dignified experience and actually start to work with healthcare teams to reduce these unconscionable disparities in maternal health outcomes that we see all over the country. But also the same principle applies as people are encountering serious illness. Do they all have the same access to respectful, dignity-promoting conversations that help their wishes be honored as they enter serious or often terminal phases of their healthcare journey? Do they have teams that see them for who they are? Are they seen by their healthcare teams? And again, is their dignity elevated at all times? So those are some of the parts of our work that we're really excited about.
I love that explanation, and I love you talking about dignity in healthcare. I don't think it's a term that's used often enough. So what have been your biggest challenges as a doctor, whether it's from the medical standpoint, working with your colleagues, to working with folks on the ground? Like, can we talk about that?
Yeah, no, it's a great, how much time do we have?
I have time. I'm like sipping my tea as you tell me. What happened?
No. Being parsimonious and pithy is a good thing too. To me, what it boils down to, Ashley, is this recurring encounter with the following fact about US healthcare, and actually global too, but let's stick to the US for a second. We do amazing work in the US healthcare system in terms of rescue. We are amazing. If you have some acute problem and, it requires ICU level care and fancy stuff. And, remember the old show ER, you're like, how we love that. There's something about in the US about acute come to the rescue moment. And we do rescue care really well. We do not do proactive, preventive, promotive, public health, community-oriented care. And actually, I would say, apropos to this conversation, we do rescue with a big asterisk. We do rescue care if you've got insurance, if you've got access, if you've got the means to interact and intersect with the healthcare system, if you're part of a dominant group or dominant narrative that like can feel like they can be seen and heard and treated fairly. And that's not everybody. And so, you know, we do rescue well for some, and we do prevention, promotion, and primary care not as well as we could for all. And you know, everything else kind of stems from that, but that's more than a lifetime's worth of work.
I know in the past we talked about this white coat like theory. Can we talk about that? Like what's your stance on the whole white coat phenomenon?
Language is super important, and language is really important because it denotes both what's said and unsaid in terms of what we mean and what we value. And so, you know, even like, we'll get into it with white coats, but there's so much in medicine that's kind of, because to learn medicine is to learn essentially a foreign language. It's about 10,000 new words. It's a whole way of kind of structured way of thinking, et cetera, but it's also not immune from all of the structural and inequitable factors that have made so much of a problem for this country. But even like I would say, I've even had to learn or unlearn things like, you know, I used to call them my medical students, and now I've dropped the possessive because I don't own them. I'm just walking with them for a couple of years, and they're, you know, a bunch of medicines. Or when people refer to patients, you know, there's a shorthand in medicine to refer to patients by like their first 3 major conditions. And people, you know, the med students sometimes present and they say, okay, well, you know, this is a such and such, and they're this, this, and this. And I'm like, actually, I thought that person's name is whatever their first name, and they live in this community. If you'd like to tell me that they have this and such issue, great, we can talk about that. But their identity is not their disease or their, you know, kind of medicalized factor. So language is so important. And so you get to the question of white coat, and I don't know, you know, the white coat thing has always been a little perplexing to me because, okay, so the roots of it, when you're a first-year medical student in the United States and in many other countries, there's literally a ceremony, Ashley, and they like bequeath this white coat on you. You go up on a stage and they put this crispy, kind of uncomfortable, hot polyester cotton blend thing on you, and it's not very fashionable. Let's just call it that. But you know, everyone in their white coat, and all of a sudden, you know, people, it's a robe. It's a signal. The semiotics behind it are that now I'm a doctor. I'm in the club. I'm in the council of shamans who can now, you know, tell people what to do and give them dangerous medicines and all that. And, you know, there's a whole group of doctors that actually don't really wear too many white coats. A lot of pediatricians, psychiatrists, primary care docs. We do it for 2 reasons, or at least I do it for 2 reasons. Number one, honestly, and there's a practical reasons, white coats are one of the dirtiest things in all of our garb. They carry infections, they're just full of bacteria and viruses, and they're just kind of gross. They don't get washed enough. And like, honestly, if you need to protect yourself from sprays of certain materials, you need to be in like plastic sheeting, which we have been during COVID for the last year. Okay, so, but the second part is like, I think that at best, white coats create distance. And actually, most patients, especially those under 50, do not like white coats because they feel the distance that it creates. Those that do are often older and sort of, you know, have from a previous generation of power differentials that, you know, a lot of us, myself included, are sort of not super interested in the white coat doctor giving you, by the way, white coat syndrome, which is a syndrome of where your blood pressure is raised when you see people with white coats, because they often have different power than you do. Maybe they have a different lived experience than you do. It's white coat syndrome. There's even something called white coat hypertension. And we know actually that if you really want to get a good blood pressure read, you learn this in primary care, you know, that you send somebody home with a blood pressure cuff because their blood pressure almost invariably is going to be lower and different at home than it is in the clinic, especially for people of color who often have experiences with the healthcare system that are not super positive.
It's so funny. Like we talked about this before, but I had no idea there was actual like real science behind that with the whole blood pressure situation or fight or flight. But it makes so
Yeah.
much sense because once the doctor walks in, the vibe changes. I don't care what was happening in the States before, but once the doctor walks in, you get nervous. You don't know what they're going to say. You don't know how to
Yeah.
advocate for yourself. And being a doctor that thinks it's really important to walk with your patients, opposed to dictating what they need and kind of listening to them. What advice do you give to the average person who is slowly learning how to advocate for themselves in these spaces and like talking to their doctor in a certain way? Like, what advice would you give them?
Well, the first thing that people say actually in modern healthcare, now that everything is so electrified with electronic health record, is can you stop looking at the computer for a second and just like, can we have a conversation? You know, can we like be in a space together? You know, I mean, even when I've been a patient, and I without going too far into it, I literally had a clinical interaction where I was a patient where the doctor had her back to me the whole time, just typing in notes. I mean, I'm like, hey, I'm over here. So I'm always thinking, like, when I'm in the clinical environment, and yes, we have to type information into the system. We have to make orders. So we can't promise 100% eye contact, but I always say, like, you know, and what I recommend to, after hearing from wise patients, is, you know, try to come to that space between you and your doctor with an agenda that you want to say. I mean, it's a conversation, right? We're going to set an agenda, and you're going to say, what's the most important thing to me as the patient? You know, here are the three things I really want to talk about. Here's what's valent to me, and here's what's like on my mind. And then as a doctor, I want to give that space to them. So I'm not going to I try to not interject for the first, 60 to 90 seconds, which is actually really hard. I talk too much, and we all talk too much, and just really letting them sort of talk about what is important, letting them set the agenda, and then really not jumping in until there's enough space given to, like, is there anything else? Is there anything else that you want to talk about? Because oftentimes another thing that I notice is that there's like an initial thing that may be really on their mind, but there's a thing that they may or may want to go into, depending on how comfortable they are. Yes. And that's actually up to the healthcare practitioner to create that space that can hold often what's the real thing. Not always. I mean, sometimes it's acute and pretty obvious and go to it, but sometimes to get to something that's deep about a fear, about an emotional state, about a worry, about a lived experience that's really difficult, or some really important thing, it's not the first two things. It's actually often the last things that you have to create a space for. And that requires a lot of trust. I mean, at the end of the day, what we're trying to do in these clinical interactions is basically signal that I am worthy of your trust, because you feel seen as a person, not just as a patient with like something wrong with some organ or some arm or something like that. Then you may entrust me with what's really going on, and you may help me understand your experience a little better. And maybe if I'm really good at my job, or if I'm really marshaling the wide resources in and around my discipline, can actually not just help you, but serve you, right?
That's beautiful. And so basically you're saying to establish trust is the onus on the doctor opposed to the patient. Because a lot of times people are looking to the patient, especially those of color, and there's already a power dynamic in that space typically. So from a patient perspective, if they're in a space where they don't feel comfortable, asking the doctor, hey, can you look at me while we're talking? Or can you explain that again? Because sometimes doctors will talk in these very big terms and not really think about the health literacy of the patient. What can the patient do from their perspective to try to make sure they're getting adequate care? I know for me as a Black American, and my dad, for example, would just take whatever the doctor would say. My mom is the opposite. She would come in with research and ask all the questions and list all these drugs that maybe her friends are taking or that she read about or whatever. Two different ways to interact with the healthcare system, right? And not all doctors are like you. I wish they were, Lord. If they were all like you, sir, we would be good. Like we would be so good. We would have like, because you get it. Like you get it. And I know you have a lot of colleagues that get it too, but there's some that don't and choose to not to. So what can patients do to get better care for themselves?
These are things that don't have easy answers, but I always tell people, your healthcare journey, your family are as or more important than anybody else. And so if you're not getting your needs met, ask questions, ask some more questions. There are many, many practitioners, providers, doctors who want and are able and have the skills and the training to see you for who you are and to treat you with the respect that you deserve. So to the extent that we can name and address the systemic inequities and racism that doesn't allow everybody to access a fair amount of treatment everywhere, we have to keep pushing and keep asking the hard questions, and also keep asking the hard questions of the institutions. Why, I really believe that institutions should all, and not all do, have robust patient and family advisory councils that are really asking them at institutional C-suite level, are you really, doing everything that you can to do to really create a space and an experience of care that is beneficial for all? And when it's not, invariably it's going to be the answer, it's not, then what are the ways in which you're systematically approaching this gap as a closure of a gap so that you can reduce suffering and improve care for everybody? That has to be as important as your P&L statement, your revenue, maximization, the new scanner you're going to buy. It's not this is the thing that drives me nuts. It's not a soft skill. I don't know what's this hard, again, language, right? Yeah. What's hard and soft? Like, if you're in the business of creating long-term healing relationships, how can you say communication and trust building is a soft skill while buying an MRI and doing a surgery is a hard skill? They're all important, right? Mm-hmm. You want that surgery to be done with as much, aptitude. You want the radiologist to read the MRI and have her come with the best reading possible. You want the doctor or the nurse to have, A+ level communication so that the person feels seen, heard, and able to entrust their care into a trusting environment.
I love that. And I have my other question with you is, you wear many hats. You're not only an executive director at Ariadne Labs, you're also an associate professor at Harvard Medical School, and you also are a practicing physician. And during all this COVID work, a lot of people were experiencing burnout. What have you done to avoid burnout and fill your cup back up in practicing self-care?
Now we're getting to the really hard questions.
Because you do a lot, and still seem like you have light in your eyes, and I think most people would be exhausted. And so what are you doing to practice self-care?
Well, I mean, it's been hard, and I'll be very, direct and honest with you and whoever's watching. If I told you that there weren't parts, especially at the beginning of the pandemic, which were just so difficult in the healthcare front lines, and also about that middle phase, before the vaccines, when it was like, is this thing ever it's not over, but is there even light at the end of the tunnel? I think it's really important, with full candor and transparency, to say that it's not always easy. Like, I don't wake up every day and say, like, I got this. I think the same kind of humility and honesty that's required to be a good healthcare provider is almost required to be for yourself, to know, like, when you're in that moment of like, hey, like, not feeling super positive or super great or super hopeful, and then sort of accessing that like, take the job titles and take the other stuff off and say, like, you're a person and you need to recharge your batteries, and like, you're basically not useful to yourself or others if you're burned out or crispy or just unable to empathize. I never got to a point where I wear, as you can say, I wear my empathy on my shoulders. Like, I didn't lose that, but like, you can get to that point of like, when the grind and when there were so many just sick and suffering people that it gets just so sad after a while. and you just feel like, is this going to ever end? And it's just, you know, I don't have any super wise things to say, except you take a break, you read a book or do something that's not, you know, in it, and then you say, tomorrow what I do know is that the sun will rise, and hopefully I will rise with it, and that I will do my best to see where things stand, and then iterate.
Thank you so much, Asaf. This is such a great, candid conversation. I really feel smarter walking out than I did walking in. And I also got to learn a little bit about your story. If you guys like this content, please like and subscribe below. And if you want to contact him and learn more about the work that he's doing, definitely check out www.ariandelabs.org to learn more about some of the amazing work that they're doing. Thank you so much. Bye.
Thank you.